and thank you for joining me to discuss the TOCALS MIU Preventative Screening Project for the frail elderly adult and its outcomes. My name is Carly and I work as an occupational therapist in the TOCALS front of house team in Llanelli. So who are we? We're the Transfer of Care Advice Liaison Service, or TOCALS, and we provide a discharge service in the MIU in Prince Philip Hospital, Llanelli. So historically, we've been dependent on MIU staff leaving patient information for us to follow up. Patients were then contacted and provided with telephone advice, signposting, or an urgent home visit. So the project was identified as since COVID, there have been service changes, a higher turnover of patients and staff shortages in MIU. We were withdrawn from completing urgent community visits and we were requested to focus on those attending MIU or admitted to the hospital. And from this then, we wanted to begin a more in-depth screening process where our front of house staff were able to identify and screen patients presenting to the MIU. We then complete preventative onward signposting and aim to reduce the number of admissions and community services the patient may require in the future. So from this project, we were able to develop 5 key pathways for the patients to follow after the telephone triaging. So these are: the patient may be signposted or referred to community services. The patient is discharged either with no input or with the Delta Wellbeing contact number. The need to signpost or refer on is identified, but the patient declines this. Telephone advice may be given, or if the patient is unable to be contacted, a letter is sent containing the Delta Wellbeing number. So the main aim of the project is to identify key areas of patient needs to reduce the risk of that patient hitting crisis point and re-attending hospital. Other aims include setting up a database to capture the screening information gathered and those contacted, forming pathways to ensure consistency with the patient's journey when completing telephone screening, creating a screening tool to document the information gathered, targeting those over the age of 60 attending MIU and presenting with falls, MSK injuries, reduced mobility and head injuries. We create additional links with the community services to maintain the patients at home, evaluating data collected to establish the quality and benefit of the project, and obtaining patient feedback comments to ensure benefit from the service user perspective. So the project met prudent healthcare principles by using a proactive approach to discussions and interventions. This is done through telephone discussions with the patient and family and using patient feedback to adapt the project. We use the patient information gathered to identify those at greatest risk of readmission, and we have developed a criteria so we do not need to ring everyone over the age of 60 and therefore save on resources. And we complete earlier intervention, avoiding hitting crisis or readmission means fewer resources used to manage the patient in the community. Patient consent is always gained to be able to complete the assessment, and the choice of the patient is always respected and considered. We allocate time at the end of the call to discuss options that the patient may want to proceed with. And the earlier intervention to avoid readmission, it means encouragement of the patient to engage in their health and social care planning earlier and reduction in duplication and repeated assessments. The main challenge of implementing the project has been continuously adapting the service as the demands of the hospital changed due to the pandemic progressing and altering. So at the beginning of the project, there's ample time to set aside to gather data and complete telephone calls. By November 2020, with the second wave hitting the country, workload within the hospital increased and there was less time to complete the screening. Due to lockdown, the patients that are now presenting to hospital are more complex in regards to their function and social needs and are therefore taking up more clinical time, and this means less time to complete preventative work. So we overcame some of the challenges by contacting IT, and they now send the patient information to us. We triage this information for the appropriate patients that fit their criteria and put this onto our database to contact. We've been using OT students to assist with completing the calls and signposting, and we ensure allocated time is used for the project and not for other clinical tasks. So the main key outcome established from the data collected within the project demonstrates a significant increase in number of people assessed. So this results in an increase of those in which the service is reaching. So the total number of patients we've screened so far between June 2020 and February 2021 is 441 patients. The following data I'm going to show is for the same period. So 71% of patients contacted were between the age of 70 and 89 years old. 72% of patients contacted attended with a fall, 13% with an MSK injury, 4% with a head injury, and 1% with reduced mobility. Most patients sat between 3 to 5 on the clinical frailty scale after telephone triaging. Although we have included the not counted section for those not contacted, they still received the Delta Wellbeing number. This graph now supports just how many more patients we are reaching since implementing the project. The yellow line graph demonstrates referral rate without the project, and the blue line graph demonstrates total figures for the service including the project. "42% of patients required some form of intervention, whether that be onward referral, signposting, or telephone advice. 20% had identified needs but declined the onward referral. So our top 5 services within the community to signpost or refer on to were the Delta Wellbeing number, the general practitioners, the Falls and Frailty team, and community physio and occupational therapy. So we've begun to collect data to evaluate the impact of the telephone screening. We've been collecting readmission statistics for 6 months following the screen, and due to this, we've only got data for June 2020 to October 2020. In this period, we screened 292 patients, of which 108 had 2 or more admissions in the year leading up to us contacting them. 38 patients had additional attendances between us picking up the referral and actually completing the telephone screen. But most importantly, 202 out of the 292 patients screened did not re-attend 6 months following the telephone call. Although initially I was a little apprehensive, my Bevan Exemplar experience has been an incredibly positive and beneficial journey in developing my skills as a clinician. I feel fortunate to have been given the opportunity to explore the service development side of this project through being an exemplar, and I feel that I've taken something new away from every session I have attended. It's been a great experience to network with others who are developing other projects within Wales, and I hope to maintain these links into the future. I would recommend anyone considering this path to take the leap and become part of the Bevan Exemplar family. So to conclude, I feel this project has demonstrated a need to switch focus to preventative care rather than the current model of reactive interventions. The COVID pandemic has created a significant increase in loneliness within the community, and those attending emergency departments are now presented with increased social care needs. We've already targeted a significant amount of patients in our local area and provided them with not only advice and support, but a friendly phone call to let them know that there are people in the community who can help. By continuing the screening, we hope to reach more of those that require support to complete low-level interventions and signposting to continue to prevent crisis in the community and future admissions. Thank you. Any questions?